we'll get started and we'll talk about brain tumors. And this is the reason I got interested in brachycephalic dogs, because this is a problem we see relatively commonly in a lot of these breeds. So if we look at incidence of brain tumors, how common are they? How big a problem really is it? If you look at humans, these are some figures from the US and the UK. So about 10 to 14, maybe up to 20 people per 100,000 will get a brain tumor. Most of us probably know somebody that's had a brain tumor. They can be pretty devastating depending on what type of tumor they are. Dogs, it's about the same sort of incidence, about 14 per 100,000 dogs. That's a bit, the data is not too great on that, but it's probably going to be a bit higher than that if you think most people with brain tumors are going to get diagnosed. A lot of dogs with brain tumors never get a diagnosis. Some of them never go to the vet. Some of them will never actually get a diagnosis beyond going to the vet and a suspicion. So it's likely that the incidence in dogs is actually quite a lot higher than that. We see lots of different types of brain tumors. So the types of brain tumors we see are similar, regardless of whether we see them in dogs or whether we see them in humans. A little bit of science for you. On the left, you can see some tumors from dogs, and on the right are some MRIs of tumors from humans, and they're very, very similar. Doesn't matter whether you're this little guy on the left or you're Teddy Kennedy, you're going to get the same sort of brain tumors. Those brain tumors can either arise from the supporting cells of the brain, the glial cells, and the classic tumors for those are the astrocytomas and oligodendrogliomas. Teddy Kennedy had an astrocytoma, a really high-grade aggressive one. The nerves in the brain itself can generate tumors, those are less common. And then the more common ones we see are the ones that come from the so-called neural crest tissue, and those are the meningiomas. And they grow on the surface of the brain, and you can see a couple of examples there at the back of the brain, both in a human and a dog. As I said, the basic biology, the more we look at these tumors, and there's a lot of interest in looking at these dogs with brain tumors because they're a very good model for human disease. And you'll be seeing that a lot, that a lot of people are interested now in giving money, doing research on these dogs because they give us insight into human disease. This is this so-called one medicine. You've heard about one medicine. There's no difference between disease in dogs and humans. They're different species, that's all. So what we learn from dogs we can apply to humans, what we learn from humans we can apply to dogs, and it should go backwards and forwards. The exciting thing for me as a veterinarian is over the last, 10, 15 years, it started going back in the opposite direction. Lots of the things we're learning about dogs we can now apply to humans, and I think Zena's going to talk to you a little bit about information that we can work out in dogs that then we go look in humans. It used to be we always used to go cap in hand to the humans saying, we've got this disease, what have you found, and let's see if it's in the dogs. It's actually going the other way now, which is fantastic. So, interesting things for me. What am I interested in? Well, we know that certain breeds of dog get brain tumors more frequently than other breeds. So, we know our breeds are highly inbred, by definition. And we know we see these predispositions. So when we're talking about brain tumors, we see the gliomas. These are the Teddy Kennedy type tumors, Seviballesteros type tumors. We see these very commonly in the brachycephalic breeds. So any of the dogs with the squash nose, most of the dogs, I should say, with the squash nose, the boxers, the bulldogs, the Bostons, very commonly get gliomas. So I just put a little bit of data up here for you. So let's look at the breeds. So what I've put here is just a little table just to bring this home for you. So if we look at, I've put the 4 most common brachycephalic dogs we see with brain tumors. The Boston Terrier, the Boxer, the Bulldog, and the Pit Bull. And I've lumped there, sorry, I did lump the English and the French Bulldogs together. Heinous crime, I know, but there you go. You never think of these things when you're talking to veterinarians. That doesn't bother them at all. But. Okay, so we've got number of tumors. So there were 9. This is just a sample of our tumors. 9 of the brain tumors came from Boston Terriers, 50 from Boxers, 8 from Bulldogs, 6 from Pups. So that's 6%. That represents 6% of the tumors. In the blue is the hospital population. So you've always got to look at what the hospital population is. I mean, if we see 3,000 bulldogs a year, then we're going to get a lot of disease in bulldogs, just by a raw number. Bulldogs represent 0.8% of the hospital population here at UC Davis, but 6% of the tumors were in Boston's. Boxers, represent about 2%. They're a slightly more popular breed. But 32% of these tumours occur in the boxers, and likewise for the bulldogs and the pit bull. If you go down, 9% of the tumours are actually in Labradors, but 9% of our hospital population is Labradors. That's obviously a very popular breed. And just on the right-hand side is other published data. Thank you. So that's pretty impressive, isn't it? If you look at this, that's a huge predisposition for these breeds to get brain tumours. So if you put all these together, the boxers, Bostons, bulldogs, pit bulls, 50%, half of all of those types of brain tumours we see in the clinic are in these breeds of dog, and yet they only represent 6% of the hospital population. That's a dramatic predisposition. There is something in these dogs breeding that predisposes them to getting brain tumours, particularly if you're a boxer. Don't know if there are any boxer people here. 50% of all of one tumour oligodendrogliomas, that's the one that Sevi Ballesteros got, 50% are in one breed of dog. That tells you that's genetic. So I'm not a geneticist, and Zina's going to cover her ears at this point because I'll probably say things which are not right. What we'd like to do is, how do we track down what the genetic cause is? There are a lot of ways of doing it, but basically what we're looking for, if these are our dog's chromosomes, we're looking for something that's common to the dog's chromosomes that's also found in these particular dogs. So for example, here are dogs that are all brachycephalic, different breeds of dogs, and we have a common region in their chromosomes. And that's how we match up that area of chromosome associated with a specific phenotype, in this case being brachycephalic. So I, a long time ago, talked to Dr. Banish, who's head of the canine genetics group here, and I said, you know, there's something going on here with these brachycephalic dogs. And we need to find out why they get their brain tumours. And the first step of that, of course, is we need to find out why are they brachycephalic. The most logical reason is that the thing causing brachycephaly may also be the thing that's causing them to be predisposed to these cancers. So we did a little study and we looked at the genetics of these dogs, and we looked at brachycephalic versus these dolichocephalic dogs. And these are the dogs that we picked. So these are the brachycephalic: pugs, bulldogs, Bostons, Japanese chin, Pekingese, Shih Tzu. And then we compared those to non-brachycephalic, classically non-brachycephalic dogs with the long snouts. One of the interesting things we can do, we use these studies called genome-wide association studies. You're all, you know, you breed, you recognize these terms. We're looking for these associations on the dog's genome with the phenotype, in this case being brachycephalic. And I'm not going to go into the details of how we do it exactly, because I can't tell you, because I'm not a geneticist, although I understand some of the basics. We generate some data, and these are the chromosomes. So we're looking at all the dog's chromosomes along here. What we're looking for is a peak, an association that when we compare squash-faced dogs to dogs with long noses, that is associated with a common region in the chromosome, and that means that region is associated and likely to contain a gene, whether it's switched on or switched off or mutated, that is causing this phenotype in these dogs. And in the case of the dogs, what we found was that on chromosome 1, there was a very highly associated region on chromosome 1 in dogs that was associated with being brachycephalic, whether you were a boxer or a bulldog or a Boston. So that tells you that it's common somewhere in the ancestry, that this genes that are causing this went off on the family tree, and dogs beyond that became brachycephalic and carried that phenotype. Terminology for you: genome-wide association studies. Those are the types of studies. SNP is something you'll hear. That just stands for single nucleotide polymorphism. Just means that one base in the DNA is changed between different animals, maybe between different breeds. Said it's on chromosome 1. Dr. Banish published that in PLOS Genetics. And the genes that are in that region are two genes. These are the candidate genes, thrombospondin 2 and SMOC2. And their functions, we're not sure at the moment exactly how they may cause brachycephaly, and probably we're going to have to look back into development. As puppies develop, that these genes may be switched on or switched off. We know there are no mutations in these genes, but we know that these genes are very highly associated. We also know that it was nice that another group, Elaine Ostrander's group, did some similar research coming from a slightly different angle and showed the same thing. It's always nice when two researchers show the same thing. It means you haven't messed up somewhere. So again, here's chromosome 1, And they've shown this nice association. So that's work ahead that we're going to do. We know the region, the chromosome that's associated. The question now is, why do these dogs get brain tumors? That's why they're brachycephalic. That's why your dogs have their squash nose, because there's something going on in these genes, probably in development. So we did the same thing again, and this time we started looking at dogs that had glioma and were brachycephalic. And you know there are certain breeds of dogs, actually interestingly, that are brachycephalic that don't get brain tumors. So I don't see very many pugs. I don't see very many Shih Tzus with brain tumors. They're not as common a breed, but actually pugs is pretty common around here. We see a lot of pugs. And they just don't seem to get brain tumors. So it's not just that genetic region in chromosome 1 that causes brain tumors. It makes them brachycephalic, but not necessarily having brain tumors. So there must be something else. And so we looked then at the brachycephalic that do have brain tumors, and the brachycephalic that don't, and see if there's a region that associates. And what we found is that if you look at chromosome 26 in these dogs, there is a very highly associated region in dogs that have brain tumors. It's a complex story. If we look in this region, again, there are some candidate genes. What we like to see is, the nice story for us would be, we look for a candidate gene, and sure enough, there's a change in its DNA, and it's mutated, and the protein or whatever it is not working anymore. That would be the nice, easy story, and that happens sometimes, and sometimes it's not quite as simple. In this region, we've got 3 genes, and these are the 3 genes that we've been looking at. We're not sure what the whole story yet is, but we do know that this is highly associated. This, by the way, see how this looks like a skyline? Sometimes geneticists will call this a Manhattan plot, which I think is kind of cool. Yeah? And basically, the taller your skyscraper is, the better the result. So you want these peaks to be as high as possible. So that would be a nice Manhattan plot. If it's a really bad study and you don't find anything, then it's a Kansas plot. Okay? No skyscrapers at all. So where are we looking at the genetics? Why are your dogs getting brain tumors? Here's one of the candidate genes. We know there's something going on. The question is, we haven't worked out exactly what the story is. Here's a group of brachycephalic dogs that have had their brain tumors. These are dogs that unfortunately went to necropsy, and we look at their normal brain and we look at their tumor. What you can see here is T is for tumor, N is for normal brain, so they're matched for each dog. What you can see is, and this is looking at how much expression we get from this gene, you can see that for each normal brain, the tumor has less of this specific gene product. And that's absolutely consistent across all these tumors. So this gene is downregulated in these brain tumors. What that means functionally, we're not sure yet, but it's certainly an association. And we can graph that. Normal brain, tumors. Normal brain, tumors, downregulation of the gene. P2X7 receptor is another gene that's in that region, association. This is an exciting gene for us because we actually did find a mutation in this gene in these dogs. There's a change in one of the base pairs, which changes an amino acid in the protein and changes the structure of the protein. The question is that significant or not? We know the gene is upregulated. Unlike the other gene, this one actually goes up in the tumors compared to the normal brain. And we have a nice collaboration going on with, I love this, with a collaborator in Wollongong in Australia, in New South Wales. He's the expert. He's actually done some dog work before, and he's helping us look at the function of this protein when it's been mutated. So that's area that's ongoing. This is the protein. This is its structure. This is what it looks like. Here's the little mutation that we found. And here's the amino acid that's changed. Slightly changes the structure of the protein, probably slightly changes its function. The question is it significant? And we've been doing some nice little studies just to show you some pretty pictures. This is what happens. This is a channel in the cell membrane. So in the cell surface, this channel, if it binds ATP, the energy molecule in the body, then it opens up and large molecules will go in. That's a normal thing. But you could imagine if that happens too much or too little, you're going to change the function of the cells. And this is particularly in white cells, the immune system. Cancer, you all have cancer going on at the moment, guaranteed. Your immune system is picking it off. It's quite scary when you think about cancer. You have abnormal cells that are occurring all the time, and your immune system picks them off all the time. The reason we get cancer is because probably your immune system is not picking them off. They're not getting taken out. So we know that this receptor is associated with the immune system, and we know that if you have abnormalities in certain conditions, certain cancers can arise. So it's a nice candidate gene. This is just showing you that when we give the ATP, all the cells shift over to this side of the graph because they're taking in the molecule that's going through their membrane. Some kind of intriguing preliminary data. How fast this assay works, we can monitor on a graph. Here are normal dogs in blue, and in red, these are brachycephalic dogs. This is what's happening to their receptor. So it looks like this receptor actually has an increased function because of that little mutation. Again, what that means in the context of specifically getting brain tumors, we're not too sure. So we don't have a genetic test, which is what you all want to know at this point, isn't it, obviously? Cut to it, get to it, where's the test? We don't have one yet because we don't understand specifically what this means. We know that it's complex. We know that the reason some of these dogs get brain tumors is probably maybe associated with the genes that make them brachycephalic, but there's something else going on as well. So chromosome 1's involved, chromosome 26 is involved. Specifically what's happening with those genes in that region, we don't know the full story yet, and it's probably multifactorial. It's probably not just a single gene. So it's going to be complex. So this is working through. We've done the easy bit. Now's the really hard work of trying to work out exactly what's going on. So genetic tests, not yet, but I think it's encouraging that we're starting to get into this disease, find out what's going on. Interesting one from this is we have some funding to look at this genetics. Why are the human people interested in this? Because your dogs are inbred, doing these genetic studies is actually a lot easier than it is to do in humans. So if you had humans that get brain tumors, they could do the same sorts of studies. Why do humans get brain tumors? But it's really difficult because humans are not inbred. You're not allowed to breed with your brother or your sister for very good reasons. Okay? To do the same study that we've done, and they've done the same study in humans, took about 5,000 controls and about 4,000 patients. And these tests, I don't know, they're about, what, $50 a dog? Something like that, maybe, ballpark, by the time you do everything. Let's say $50 a dog. You can imagine we did it with about 60 or 70 animals. Because the genetics is much tighter, there's less variability, there's not all that background noise because they're very inbred. In humans, there's all the background noise because everybody is very different. Thousands, imagine, $50 times thousands. It gets very expensive, much more powerful in dogs. If we find the genes in dogs, then we go and look and see if the same genes are in humans. So it's very powerful, and it's a reason why a lot of our medical schools are wanting to work with us on these sorts of diseases when we see the same disease in humans as we see in dogs, and brain tumors is a great example. Okay, so I'm going to go through just for you to give you all background, where we are, what are we doing with these tumors, how do we diagnose them, how are we treating them, what are the advances in that. Brain tumors is a little difficult because, as you all know, it's difficult to get a diagnosis. It's expensive to get a diagnosis. It's not like having a skin lump or a little lump in your liver where they can easily get a sample to make a diagnosis. Dealing with the brain is a little bit more difficult. It often involves these advanced imaging techniques like CT and MRI, which are wonderful, but they are expensive. So imaging is a big part of that. Older animals with brain tumors, really important. If you take your animals to a veterinarian, to a specialist who's going to work your animal up, you need to look in the rest of the body. Quarter of animals with brain tumors will have cancer elsewhere, and not necessarily the same cancer. So it's really important you spend your money up front on some basic tests. It's well worth it. It's very hard when they say it's going to cost you $2,000 for an MRI, and I want to charge you an extra $300 for an ultrasound and an extra $100 for a radiograph. That money up front is really well spent, because obviously a quarter of these animals, we have some significant conversations about, are we going to go forward and spend $2,000, $3,000 because we find other things as well. So that's a really good tip for you. Imaging, lots of different types of imaging. We can look at spinal fluid. We can do biopsies. And at the end of the day, if you want to know what's wrong with your animal, you need to look under the microscope at what that tissue is. Very easy for a skin lump, a little bit more challenging if you've got a brain mass, because it's more difficult to get a sample, but we can do it. MRI is probably the imaging modality of choice. It's great. We get these beautiful cross sections. This is a dog. Here's the brain tumor. Here's all the edema. See these little fingers going out? That's the edema, the swelling that the tumor generates in the brain. Doesn't matter whether you've got a brain tumor or you've got swelling. The end result is the same. The brain gets squashed. The swelling is just as important as the brain tumor for making those clinical signs, whether that's seizures or circling or behavior changes. So we can do quite nice things to treat this swelling. It's a little bit more difficult to treat the tumor itself. I'm going to show you a case because, again, this is another. I put this one in as a tip for you as owners. If you ever end up having an animal, one of your dogs has a brain tumor or suspected having a brain tumor, what you should be asking from your specialist when they're working them up. This is a little dog that was sent up to us for a brain biopsy because they saw this little mass. Here's the skull of the dog. This is right at the back. Here are the muscles on top of the head. This is right at the back of the brain, and this is the cerebellum and the brainstem right at the back. And what they saw was pre-contrast, post-contrast is this little lump here that looks like it's enhancing. And that's a mass within the cerebellum, and they sent the dog up here for a biopsy. We were a little suspicious because the dog's clinical signs didn't fit with that mass. This is why you go and see a neurologist. I'm biased, but that's okay. If your dog has a neurological problem, you want to go and see a neurologist. I have huge respect for general practitioners. They do an amazing job. They have to know everything about everything, and that's hard. But if your dog has a neurological problem or a respiratory problem, my advice is once you've gone to GP, you should be thinking about referral. The reason is because those people are good at what they do. We were suspicious this dog's signs didn't fit with where his problem was. So we suspected maybe there's something else going on, and we redid the imaging, and we did an MRI. And sure enough, there's that little lump. You can see it on the MRI, just like we saw it on the CT. But when you look at the whole of the MRI, we're going to go through from the front of the brain to the back of the brain. Here's the more normal brain, and then all of a sudden this white area starts coming up all the way through the back of the brain. Everybody see that? All of this area is abnormal. The little mass was in there, but the whole of this area is abnormal. And you only really see that on an MRI. Here's the CT. Great for looking at bone, not as good for looking at the brain, but on the MRI you can see these amazingly diffuse. And this is a glioma. It's like a Teddy Kennedy tumor, but it's very diffuse and it's spread through the whole of the brainstem. The reason I put this up for you is, if your dogs are going to be worked up for brain disease, you should be demanding MRIs. CT was okay 10 years ago when people didn't have access to MRI, but people have access to MRI now. Don't waste your money on a CT. Because if you end up going to a specialist, they're going to do an MRI anyway, because you miss things on a CT. If that's all you've got, okay. But if you have the choice, you need to be pushing to get an MRI. The other thing you need to remember is, as good as we think we are, it's only a picture. It's a very nice picture, but it's still only a picture. Here are 4 dogs with lesions in their brain that look very similar. These sort of ring, contrast-enhancing lesions. They all look like brain tumors, but they're not. That one's a dog with inflammatory disease. That one has a fungal infection. This one's a hemorrhage. That one is a tumor. So again, you need to be having conversations. Even when you've done the MRI, you need to be thinking, we shouldn't make assumptions. Maybe we need to biopsy. And we can biopsy the brain. We're very lucky we have biopsy facilities here. More specialists are getting these sorts of facilities. As I said, at the end of the day, if you want to know what's going on with your dog specifically, you look at that mass under the microscope. That's the best way we can have a conversation with you about what the optimum treatments are. It doesn't mean we have to do it in all cases. Sometimes we make an educated guess and we sit down with you and say, there's a 90% chance this is a brain tumor. Let's go ahead and treat, as long as we're okay that maybe we get it wrong. But to be honest, for me, I'd like to know before I start doing treatments. And treatments, as you know, for these sorts of diseases can be quite involved and quite expensive. So I think it's better to know what you're dealing with specifically. Here's a little biopsy. Here's some imaging. We actually use CT and MRI to do our biopsies. Here's the tumor. Here's the biopsy needle going into the tumor. We guide it in there under the imaging, and then we can get these little samples and we can get a specific diagnosis. In this case, this is an oligodendroglioma. in a dog in the ventral part of the brain there. This biopsy system was developed by Dr. Lakuta and Dr. Koblik, who died of a glioblastoma. Kind of ironic, isn't it? And this is Trent Wells, who's a guy who developed a lot of the human biopsy systems. So we have that technology. A lot of places do. It's something you should be thinking about. Again, you're allowed to ask questions. I'm sure you all do. If somebody says you've got a brain tumor, you should be asking them, what else could it be? You know, if they tell you it's absolutely a brain tumor, guaranteed off an MRI image, you should be going somewhere else. A good clinician will tell you it's probably a brain tumor. There is a chance it could be something else, and they should be talking with you about that and about options to biopsy. To biopsy a tumor is about $2,000. It's not cheap. So sometimes it's okay to go ahead and treat without biopsy. Other times, depending on what the treatment is, you probably want to know. So where are we going treating these? I think the most important thing you need to get out of this is it's not all depressing. Again, 20 years ago, maybe even less than that, you go to your practitioner, and if they suspected a brain tumor, that was the end of it, wasn't it? You know, there's a joke that goes around our department, the other things, the 3 Ps. How do we treat brain tumors? Prednisone, phenobarbital to stop the seizures, and pink juice, which is euthanasia. You know, kind of depressing, really, isn't it? They joke at us, oh, it's a neurology dog, give it the 3 Ps. You know, this is so not true anymore. Okay, some of these brain tumors can be very effectively treated, sometimes years. And you think most of these animals are quite old when they're treated. That could be the rest of the dog's life, and they can die from other diseases. So it's time to move forward, and it has moved forward. Treating brain tumors is pretty similar to treating other cancers in a lot of respects. We can do palliative treatment, so all that swelling I told you about, we can treat it with corticosteroids, we can get that swelling down, and you can get a dramatic response and buy a lot of time for a lot of these animals. We can control seizures if that's one of the clinical signs that comes with the tumors, and we can decrease that edema. So that can work for some animals, and maybe that's the best approach for some animals. Owners and their pets are all different. Some owners want to be aggressive, some owners don't want to be aggressive. Some owners with certain pets want to be aggressive. Some dogs will tolerate, and owners know that those dogs, it's reasonable to try and treat this. Other dogs, not a good candidate, and that's an individual choice. Ideally, we'd like to remove the tumor surgically, get rid of as much as we possibly can. That goes for most cancers. Particularly for certain types of tumors, the ones I talked about, the meningioma on the surface, a lot more amenable to surgery. We're having a lot more success now with some of these deeper tumors, the Teddy Kennedy type tumors, and I'll show you some examples of that. Radiation therapy is another option, either straight away or after surgery, and I'll tell you a little bit about that because we've got some exciting developments here with radiation with Dr. Kent. That's particularly useful for tumors that we don't want to go after because we don't think we can get them surgically. Chemotherapy, kind of limited on its own. Sometimes we use it in addition. And then there's some experimental therapies which are in development, and there's a lot of exciting therapies that are being developed in dogs. Actually, a lot of them being done to try and look at what we can do in humans as well. So I've put this one in. Let's go on to surgery. We'll talk about surgery. As I said, it's cancer. If you can cut it out and get rid of it, that's great. This is actually a cat, and you can see these are cat tumors. These are meningiomas in cats. These are pretty benign tumors. We fight over these surgeries. This is a cat that actually went to necropsy for something else, but this tumor actually fell off. Yeah? That's how easy those ones are to resect. Okay? So that's a great candidate to do surgery on. Not all tumors are that easy. Some of them, like this meningioma in a dog, is right at the bottom of the brain. That's not in an area we can get and do surgery without causing a lot of damage to the dog. We're very lucky. We have a really good team here. Dr. Sturgis heads up most of the cranial surgery that we do. The types of surgeries, here's a dog. Again, this was another meningioma. You can see this large tumor here. This is before surgery. This is after surgery. Pretty much a complete resection of that tumor. You're going to get a good clinical response. You're going to buy these dogs years, potentially, of good quality life. You can see the little dark you can see here is where Dr. Sturgis reconstructed the skull on the outside. Sometimes the tumors occur at the back of the brain. Here's the nose, here's the tail, or going down the neck rather. Here's this tumor growing. See a large tumor right underneath the cerebellum here. But again, These can be surgically resectable. Here's post-op. These are challenging surgeries. You really need specialist equipment and specialist training to do this, but it is possible, and you can get good results in some animals. If you have the tools, you can do the surgery. Again, there have been advances in neurosurgery. This is common practice in humans. It's just being developed we're just starting to use it in our dogs now, but this is actually using the imaging that we use to do the biopsy in real time in the surgery, so we know where we are in the surgery. So we have some little screws we put in the dog's skull, and we have a camera that basically has the MRI image on it, and it knows where the little pointers are relative to the dog, relative to the tumor, and it puts it all together so that when you put your pointer somewhere in the surgery site, it tells you where you are on the MRI, and you can actually find out exactly. Isn't that amazing? That's standard. That's absolute standard of care if you have neurosurgery as a human. It's just starting to be used now in veterinary medicine, mainly because we've got some equipment that's being made specifically for us, but also because we're now starting to get into these techniques. So that's where we are. That's cutting edge, doing these sorts of tumors. If you have that technology, you can start to address some of these more extensive tumors. And we also have some other toys, microscopes, these little tools that allow us to suck the tumor out without damaging the rest of the brain. I'm going to give you an example. Here is an intraaxial tumor deep in the brain itself. These are sections going from the front of the MRI to the back. Here's an image from the side. Here's this large tumor. You can see it's right in the middle of the brain. This is a surgery Dr. Sturgis did, before surgery, after surgery. Okay? Essentially resected almost all of this tumor. There are going to be some little individual tumor cells there, but this now means that treating with other things like radiation is going to be so much more effective. And this dog went on for almost 2 years afterwards. And this was a 10-year-old dog, I believe. That's pretty good. We're happy with that outcome. Radiation therapy. Probably the most common used therapy outside of surgery. There are some data out there if you go onto the web telling you how well radiation can do, but at the end of the day, there's not a huge amount of data out there, so you've got to be a little bit careful what you see on the web. We think that basically if we do the radiation, we probably get maybe a year if you're just doing radiation alone for most of these aggressive gliomas, as I say, the Teddy Kennedy type tumors. You'll buy a year, maybe longer than that. If we can do surgery first, maybe you're going to get a lot longer than that. So they're not cures. They come at a price. It's about $6,000 to do radiation. So it's an expensive technique. Dr. Kent, who heads up the radiation service here, they've just got a brand new linear accelerator. This is cutting edge. It is, not that it's a competition, this is better than the one they have at the med school. And it's going to be used for research. That's the reason it's here. It's going to be used for research as well as for treatments. And it does this so-called stereotactic radiation, where you come from lots of different angles with lots of beams. We can give a very high dose to a very specific area. So it's a fantastic tool. One of the nice things is that our old radiation systems, we used to have to do 20 or 30 treatments, which means 20 or 30 anesthesias for the dog. We can do this in 1 or 2 treatments now. So that's a huge leap forward. Chemotherapy alone, it's kind of okay. Maybe palliative, along with palliative care, but on its own, it's probably not going to cut it for most of these tumors. So what I'm going to tell you now, I'm just going to finish off with where we're going, where the exciting stuff is beyond the standard. And the standard therapy has advanced a lot in the last few years. So we're buying years for some of these dogs now with these tumors. Have you all heard the adverts on the television about Cancer Centers of America? Come to us, personalized medicine. We'll work out what your genetics of your tumor is. This is what we're talking about now, is that we look at the actual genetics of each individual tumor and see what the abnormalities are with that tumor, and we target or make a therapy specifically for that tumor. And the way we do that is we look at the genetics of the tumor. What's going wrong? And this is an example. This is a dog tumor. This is a glioblastoma. It's in a boxer, it happens to be. And we look at all these pathways, all these proteins that are abnormal. Here's the normal brain, what we should see. Here's the tumor. And you can see a lot of these things are upregulated, out of control in these tumors. And that gives us a target. If we can shut off that specific protein, maybe that'll help us to get the tumor under control. Sometimes what we do, we don't care what the pathway is. We just want a marker on that tumor. It's like the tumour's walking around with a red flag on it. And if you can spot that red flag, you can target those tumour cells. So these are a couple of examples that we've looked at. There's an interleukin receptor, an EPH receptor, alpha-3 integrin. If the tumour cells in yellow express that, we can make a toxin that will bind to it and will kill the tumour cells, but it doesn't bind to the normal cells because they don't express it. There's a clinical trial going on at the moment with some of our collaborators in Virginia with dogs using that targeted therapy, and they're also doing it in humans as well. That's one example. The other example I'll give you is that these are all these cancer pathways. You may have seen some of these sometimes, that these very complex pathways that turn cells on, make them divide, make them die or not die. All these proteins are produced from the tumor cells as well as normal cells, but sometimes they're aberrant. In this case, we can see some of these growth factors. They bind to receptors on the cancer cell surface and drive these pathways that make the cell divide. And we can see in this particular tumor, this part of the pathway is upregulated. These receptors are upregulated. If we have drugs which will shut those pathways off, then it's likely that this tumor will respond. If this pathway is not activated in your tumor cells, then there's no point giving the drugs because you're shutting off a pathway that's not really active. That's where that personalized medicine, Cancer Centers of America stuff comes in. They'll look at your tumor and they'll see what's switched on and switched off, and then they'll match the drugs to those pathways. And there are lots of those drugs coming out. Just another example of what part of the pathway that's upregulated in this dog. There are 2 drugs at the moment that have actually been licensed for dogs. One of them is called Palladia, which would switch this potential pathway off. There's hundreds of experimental drugs for humans, and we're starting to look at those in dogs. But before we can look in dogs and use them in the clinic, we have to know what's switched on and switched off in the dogs, and that's why we do the research to look at these pathways. One of the other things that we've looked at specifically is looking at how do we get the therapies into the brain tumors themselves, because it's a problem sometimes giving drugs to dogs or humans to get enough into the brain. And one of the ways we can do that is to actually bypass giving them into the bloodstream and just put them straight into the tumor. And we've done that with quite a few dogs here where we put little catheters down into the tumor and just inject the tumor with chemotherapy. Huge doses. You wouldn't be able to give those doses normally because the side effects, the nausea, hair loss, all those sorts of things will be too great. But because we put it right into the tumor, we can give enormous doses. And we can get some quite dramatic responses. Here's a tumor. This is the area, this is the tumor before treatment. This is the infusion. You can see it in white going into the tumor, and we can watch the infusion when we do the MRI, and then this is after treatment. The black you can see down the side here is actually normal. That's the ventricle that's come back. And the little area of black you can see there near the arrow is what's left of the tumor. This is just to show you how we do it. Here's the tumor. There are actually 3 catheters that we've put in. This is just watching over time as we pump the chemotherapy into the tumor. We can watch and we can see we didn't get this part of the tumor, so we'll put another catheter in. And then we'll start infusing in that catheter. And if that doesn't fill the part of the tumor we want, so we've got a little gap here, so we'll put another catheter in. And that way we can watch the infusion. Ideally, we'll fill as much of the tumor as possible with chemotherapy. And that's the way we're going to get our best response. So that's ongoing. That's a research that I know some of the people here were involved with. It's ongoing research. We're on to our 2nd generation of drugs now. This trial actually closed. This was using a drug called CPT11, which is a chemotherapy. Based on the data we got on that, some of the dogs responded very well. Some of the dogs didn't respond. It's a chemotherapy. Not all tumors are going to respond to one chemotherapy. So we're looking for better and better chemotherapies and mixtures. So that trial closed. We're hoping to open another trial in the next year using some slightly different drugs and different combinations. The exciting one for me is that the imaging technology so you could see the infusion going in, which is pretty cool. It's important because you need to know where it goes. You need to know it actually is going in. That's something that was developed in the dog. And this is an example. This was a patient at UCSF that got the same type of treatment. Same thing. This is where they had their tumor resected, and there's some tumor regrowth here, and they're using the same technique to infuse chemotherapy. Actually, this is a viral therapy they were injecting into the humans. So it's a great example of where the dog informs some of the things we're doing in humans. So they're common in your breeds of dogs. We see them very commonly compared to other breeds. There is a genetic predisposition. We're working on that at the moment. If you're going to have a dog that's worked up, make sure you push for an MRI, not a CT. And look at the options. I'm not saying we can treat all brain tumors, and I'm not saying all dogs are going to do very well, but a larger and larger number of animals are getting good outcomes from the treatments we have. It's not the doom and gloom that it used to be. So you need to ask. Give us a call. We're always happy to talk to you. We're always happy to tell you what the options are. We're not going to spin you a story and tell you come and do something. Okay? We're going to be pretty realistic with you. And I'll tell you now that more than half of the owners I talk to that want to go onto trials, I don't let them go onto trials because I don't think it's in the dog's interest. And the owners don't either by the time we've talked. So, but it's always good to talk because a lot of animals can be treated. The corticosteroids can be very effective, as can some of the standard therapies. And we know that these novel therapies are going to be coming through. Next 10 years, 15 years, hopefully we're going to make some big advances as well. Okay, thanks everyone.